So welcome back. Let's keep reading. Step 1, USMLE, first A 2025. So interleukins. Interleukin is a group of proteins that act as a chemical messengers between cells, primary white cells, to regulate immune response. So they are a type of cytokine, which are signaling molecules that mediate communications between cells. So interleukin play a crucial role in inflammation, cell growth, differentiation, and motility. So we got here important cytokines. So we had a whole group of cytokines that we have secreted by macrophages. We have the group of secreted by T cells, and we have another group from Th1. So the group of secreted by macrophages, we have interleukin 1, interleukin 6, tumor necrosis factor, interleukin 8, and interleukin 12. So important cytokines. We have the acute group, this one here, the acute group, acute. Now we have interleukin 1, interleukin 6, and necrosis tumor factor alpha. Then the group that recruit, they call for more cells into the inflammation. We have interleukin 12 and interleukin 8. Interleukin 8 is important, very high GL. Interleukin 8, they recruit, they call for more cells, inflammation cells. So we have the first one, interleukin 1. Interleukin 1 causes fever, acute inflammation, activates endothelia to express adhesion molecules. So interleukin 1 induce chemokine secretion to recruit white blood cells. It's also called osteoclast activating factor. This is very high GL. Osteoclast activating factor. We're gonna see that a bunch of times. Also called osteoclast activating factor. So interleukin 1 is also called osteoclast activating factor. So interleukin 6, we have here interleukin 6. Interleukin 6 causes fever and stimulate production of acute phase protein. The tumor necrosis factor alpha activates endothelium, causes white blood cells recruitment, and vascular leak. When you say vascular leak, it means that it allowed that the vascular let the cells go through their walls to the inflammations area. So tumor necrosis factor activates endothelium, causes white blood cells to recruit, and vascular leak. Causes cachexia in malignancy. This is very high G. I have seen that question too. So cachexia, what is the element that is drive through? Cachexia is tumor necrosis factor causes cachexia in malignancy disease. So maintain granulomas on TV. So this is another high GL, because when you give medications of anti-tumor necrosis factor and they have TV, they break the wall and they release the TV. So let me explain better. When you have TV, your body engulf the TV bacteria, and it keep it like in a capsule. It keep it maintained in the lung so it doesn't spread. So that, with the help of necrosis, tumor necrosis factor alpha. So if you give some medications that block the tumor necrosis alpha, if the patient have TV history, you're gonna release the TV into the body. So this is a very common question. They always ask for that. The way they usually ask it is, they find out a patient have some kind of immune disease, and they're gonna need to give them some tumor necrosis factors inhibitors. And then what is the most important test you have to do before giving that medication? The answer is give it a TB test, tuberculosis test. Okay, that's the way they ask that question. So the necrosis, tumor necrosis factor, remember, maintain granulomas. Granuloma is the thing that maintain the TV encapsulated. Maintain granulomas and TV, cause cachexia and malignancy, and then interleukin-1, interleukin-6, and tumor necrosis factor alpha can mediate fever and sepsis. They can mediate fever and sepsis. The most question that they have all the time for fever is interleukin-1. Remember that interleukin-1 is, but interleukin-6 and tumor necrosis factor are associated with fever too, but the principal is interleukin-1. So let's see, interleukin-8 is the major chemostatic factor for neutrophils. Interleukin-8 is the major chemostatic factor for necrosis. Chemostatic factor mean that bring cells into the necrosis area or into the inflammation area. So interleukin-8 call for more cells to come into the inflammation area. Interleukin-8 major chemostatic factor for neutrophils. Do you remember, if you think about clean up on aisles 8, when you go to McDonald's or when you go to a Walmart, and you hear over the speaker, over the roof of the speaker, you hear, please clean up on aisles 8. So because interleukin-8 are recruiting for interleukin-8 to clear infection. So the neutrophils are the cells, they have to come into the inflammation to clean all the mess that there's in this process of inflammation. So that's why it'll make you to remember that clean up on aisle 8. That means neutrophils are recruiting by interleukin-8 to clean infections. Okay, let's see, interleukin-12 induce differentiation of T cells into Th1 cells. Interleukin-12 induce differentiation of T cells into Th cells, activates necrosis factor, and facilitates granuloma formation on TB. Okay, so the next group is the group secreted by T cells. We have here interleukin-2. Interleukin-2 stimulates growth of group of helper cytotoxics and regulate T cells and necrosis factor cells. Non-necrosis factor, natural killer cells. So interleukin-2 secreted by T cells. So interleukin-2 stimulate the growth of helper cytotoxics and regulate T cells and natural killer cells. The interleukin-3 is support the growth and differentiation of bone marrow stem cells. They functions like a GM-CSF, that mean granulocyte macrophage colony stimulating factor. Granulocyte macrophage colony stimulating factor. This stimulates the proliferation of the eosinophil, basophil, neutrophil, and monocytes. So remember, interleukin-3 support the growth and differentiation of bone marrow stem cells, but because they have the function of they have the function like the granulocyte macrophage colony stimulating factor, and they stimulate the proliferation of the eosinophils, basophils, neutrophils, and monocytes. From the other group, from the Th1 cells, we have interferon gamma Interferon gamma is secreted by natural killer cells and T cells in response to antigen or interleukin 12 from macrophages. It stimulates macrophages to kill phagocytized pathogens. It inhibits differentiation of Th2 cells. Induce immune globulin G isotype switching in B cells. So interferon gamma is important because they give the order to immunoglobulin They induce the immunoglobulin G isotype to produce switching in B cells. Remember immunoglobulin G. From the other side, from the Th2 cells, we have interleukin 4, interleukin 5, interleukin 10, and interleukin 13. So interleukin 4 induce differentiation of T cells into Th helper 2 cells, promote growth of B cells, enhances class switching to immunoglobulin E and immunoglobulin G, like the other one, interferon gamma. That's gonna help you to remember if you say, I'm not proud to beg for help. I'm not proud to beg for help. So that makes you to remember that the interleukin 4 promote the growth of B cells and promote the class switching of immunoglobulin E and immunoglobulin G. So we have interleukin 5. Interleukin 5 promotes the growth and differentiation of B cells, enhances the class switching to immunoglobulin A. It stimulates the growth and differentiation of eosinophils. And I have 5 babies, like I have 5 babies or 5 lovers, something like that. Interleukin 5 promotes the growth and differentiation of B cells, enhances class switching of immunoglobulin A, and stimulates the growth and differentiation of eosinophils. So interleukin 10 is important because it's like a regulatory interleukin. They attenuate the inflammation response. They decrease expression of MHC class 2 and Th1 cytokine. They reduce the inflammation. Okay, so they are regulatory interleukin 10. So inhibits activated macrophage and dendritic cells. Also secreted by regulatory T cells. So interleukin 10, remember, and transforming growth factor beta. So the transforming growth factor beta and interleukin 10, they both attenuate the immune response. So you can see here better. So interleukin 10 attenuates inflammatory response, decrease the expression of MHC class 2 and Th1 cytokines, inhibit activated macrophage and dendritic cells, also secreted by T cells regulatory. This TGF means transforming growth factor beta. The transforming growth factor beta, let's read about that. So the transforming growth factor beta is a family of cytokines with crucial role in various cells processes, including the cell growth, differentiation, and immune response. It is a key regulator development and tissue repair. Disruption of transforming growth factor beta significant can lead to various diseases, including fibrosis and cancer. Okay, transforming growth factor. So remember, transforming growth factor beta and interleukin 10, they both attenuate the immune response. So we have interleukin 13. It promotes immunoglobulin E production by B cells, and induce alternative macrophage activation. That's a good mnemonic. Interleukin 13 promotes immunoglobulin E. So this is the mnemonic they they give us here to remember the word hot T-bone stick. Hot T-bone stick. Hot T-bone stick. So hot T-bone stick. Let's see, interleukin 1 for fever, hot. Interleukin 2 stimulate T cells. Interleukin 2 stimulate T cells. Interleukin 3 stimulate bone marrow. Interleukin 4 stimulate immunoglobulin E production. Interleukin 5 stimulate immunoglobulin A production. Interleukin 6 stimulate acute phase protein production. Remember, clean up in IL-8. That tell you that interleukin 8 is more for clean infection. I'm not too proud to beg for help. They'll tell you that interleukin 4 is a stimulate process of helper, T cell helper, promote growth of B cells, enhance class switching from immunoglobulin E and G. I have 5-beta that tell you that interleukin 5 promote the class switching of immunoglobulin A and E, stimulate the eosinophil. You guys have to read this again. This is very important. So let's read about respiratory burst. Respiratory burst, also called oxidative burst, involve the activation of the phagocytic NADPH oxidase complex, by example, neutrophils and monocytes, which oxidize oxygen as a substrate, play an important role in the immune response. They give you the rapid release of reactive oxygen species, ROS, reactive oxygen species. Remember, NADPH play a role in both the creation and neutralization of the ROS, reactive oxygen species. Myeloperoxidase contain a blue-green heme-containing pigment that gives sputum its color. That's what some people say sometimes, like, oh, I'm coughing with a green sputum. I think I'm getting worse. They actually, I would say they're getting better. So, myeloperoxidase contain a blue-green heme-containing pigment that gives sputum its color. NO's safe microbe, no safe microbe. That make you to remember that NHDPH oxidase produce superoxidous dismutase. This one produce myeloperoxidase. Superoxidous dismutase gonna form later myeloperoxidase. So you can see here in the graphic. With this respiratory burst, there's no safe microbe. There's no safe microbe. No make you to remember NADPH oxidase producing superoxidous dismutase, and then this one produce myeloperoxidase. So that's make you to remember to no safe microbe. This is the first 3 steps here in this graphic. No safe microbe. No safe microbe. No is for NADPH oxidase, superoxidous dismutase, and myeloperoxidase. This is the 3 first step on the process here. When this is the neutrophil cell membrane. This is the bacteria. They just phagocytate, and then once you phagocytate the bacteria, you're gonna kill it through this process. So remember, if you have deficiency of the NADPH oxidase, you're gonna have chronic granulomatous disease. Chronic granulomatous disease. So we have a question here very related what we're just reading. So it's a 4-year-old boy is being evaluated due to severe and recurrent infection. He has been hospitalized 3 times with pneumonia since birth. He was also had a multiple skin infection that have required treatment with antibiotics and fungal agents. The patient's neutrophils failed to turn blue. The patient's neutrophils failed to turn blue following exposure to neutroblue tetrasodium. This is some kind of test. Neutroblue tetrasodium. So the patient's neutrophils failed to turn blue following exposure to neutroblue tetrasodium. Which of the following substance is most likely produced by the microorganism responsible for these patients' infections? So we have the options beta-lactamase, catalase, coagulase, lecithinase, and polysaccharide capsule. So which one you guys pick? The answer is catalase. Let's read about that catalase. So the failure of these patients' neutrophil to turn blue in neutroblue tetrasodium testing is characteristic of chronic granulomatous disease. Chronic granulomatous Remember, neutroblue tetrasodium testing is to diagnose chronic granulomatous disease, a condition most often caused by X-linked mutation affecting NADPH oxidase. So chronic granulomatous disease is a condition most often caused by X-linked mutation affecting NADPH oxidase. This enzyme normally functions within activated phagocytes to produce reactive oxygen species. That's the superoxygen. By example, oxygen, superoxygen. They act directly as an antimicrobial agent and also activate granuloma proteases. Okay, so this enzyme normally function within activated macrophages to produce reactive oxygen species. That act directly as an antimicrobial agent and also activate granulome proteases. By example, la elastasis and la catepsin, they are present in the phagosomes. And inactivation mutation in NADPH oxidase cause impaired intracellular killing by the neutrophils and macrophages, leading to recurrent bacterial and fungal infection. So remember, inactivating mutation in NADPH oxidase cause impaired intracellular killing by neutrophils and macrophages, leading to recurrent bacterial and fungal infection. Those infections are usually caused by a catalase-positive organism that can destroy the hydrogen peroxide produced by their own metabolite activity. In contrast, catalase-positive organisms cannot prevent the accumulation of bacterially generated hydrogen peroxide within phagosomes, allowing for some microbicidal activity independent of host superoxide production. So there's some bacteria they can produce their own hydrogen peroxide, and then they can destroy by themselves. So let me read again. Those infections are usually caused by catalase-positive organisms that can destroy the hydrogen peroxide produced by their own metabolic activity. So the catalase positive, they can destroy their own hydrogen peroxide produced, but then the catalase negative organism cannot prevent accumulation of bacterially generated hydrogen peroxide within phagosomes, so allowing the some microbicidal activity independent on the host peroxide production. So there's some organisms more susceptible to be attacking those patients with chronic granulomatous disease. Those are the catalase positive organism. Catalase positive organism. Remember that. Make that relation. That the test for this chronic granulomatous disease is nitroblue tetrazoline testing. So it doesn't turn blue. And then the deficiency, it is NADPH oxidase, and you're gonna have a lot of infection for fungals and bacterial caused by catalase positive. The other answers are beta-lactamase. Remember, beta-lactamase is an enzyme produced by bacteria that confer resistance to beta-lactam antibiotics, for example, penicillin. So there's some bacteria that produce beta-lactam and can produce beta-lactamase. Those beta-lactamase destroy the power of the penicillin to destroy them. So they produce beta-lactamase. So beta-lactamase is an enzyme produced by bacteria that confer resistance to beta-lactam antibiotics, for example, penicillin. In this case, you can use penicillin. You have to change to a different can. In this case, you can use beta-lactamase inhibitors like clavulanic acid, tazobactam, and sulbactam. Those are the group of beta-lactamase inhibitors. Another option is a Wells coagulase. It's an enzyme produced by Staphylococcus aureus that activates prothrombin, resulting in a conversion of fibrinogen to fibrin. This process leads to fibrin coating of the organism and resistance to phagocytosis. That's the coagulasa. Coagulasa is an enzyme produced by Staphylococcus aureus. The option D is the lecitinase, or a alpha toxin. Is an enzyme with phospholipid C activity and the major virulence factor produced by Clostridium perfringens. The toxin increases platelet aggregation and adherence molecular expression on leukocytes and endothelial cells, resulting in vaso-occlusion and ischemic necrosis of affected tissues. That's the way that the damage produced by the Clostridium perfringens. That's why they call it the bacteria that eat flesh. But really, they produce this enzyme. It's an alpha enzyme called lecitinase, and then it's an enzyme that phospholipase C activity is an enzyme with phospholipase C activity and the major virulence factor for this Clostridium perfringens. This toxin increases platelet aggregation and adherence molecular expression on leukocytes and endothelial cells, resulting in vaso-occlusion and ischemic necrosis of affected tissues. That's the weight mechanism of action of Clostridium perfringens. The next option would be polysaccharidase capsula expressed by some organism. The polysaccharidase capsula expressed for some organism, for example, Haemophilus influenzae, Streptococcus pneumoniae, inhibits phagocytosis by macrophages and neutrophils. The recognition of the capsular antigen by the immune system leads to effective phagocytosis and killing of endocapsular organism. So this polysaccharide capsula expressed by some organism, by example, Haemophilus influenzae and Streptococcus pneumoniae, they inhibit the phagocytosis by macrophages and neutrophils. To remember, features of chronic granulomatous disease. Features of chronic granulomatous disease. The pathogenesis is inactivating mutation affecting the NADPH oxidase. Remember, NADPH oxidase. So we're gonna have to remember that NADPH, it's called nicotinamide adenina dinucleosido phosphate. Nicotinamide adenine dinucleotidophosphate. The NHDPH is a coenzyme essential for all the organisms. It's a molecule that acts as a donator of electrons. It's very useful for multiple metabolic reactions, especially in biosynthesis. NHDPH, nicotinamide adenine dinucleotidophosphate. Nicotinamide adenine dinucleotidophosphate. Oxidase. So inactivating mutation affecting inactivating mutation affecting the NADPH oxidase. So that's the part of the pathogenesis. And then we have the impaired respiratory burst, inhibit phagocytic intracellular killing. So that's another mechanism of how chronic granulomatous disease happen. There's going to be impaired respiratory burst, inhibits phagocytic intracellular killing. So the clinical manifestation is going to be recurrent infection with catalase positive bacteria and fungi. There's going to be lung, skin, and lymph node and liver most commonly infected or in both, and diffuse granulomatous disease, diffuse granuloma formation. There's going to be diffuse granulomatoma formation. The diagnostics is going to be done by measurement of neutrophil superoxide production, measurement of neutrophil superoxide production, and you're going to do cytometry flow. Is the preference DHR flow cytometry. So the DHR mean the dehydroodamine. The DHR flow cytometry test is the diagnostic tool to use to evaluate the functionality of the neutrophil, especially their ability to produce reactive oxygen species, ROS, that we talk about, as part of the oxidative burst. It is very common used for diagnose chronic granulomatous disease. So DHR flow cytometry and the NBT test, nitro blue tetrasodium. So the DHR is more preferred. So if they have a question about that, so don't pick nitro blue. You have to pick this one first, the DHR, dehydrorodamine, dehydrorodamine. So again, repetition. Chronic granulomatous disease is an X-linked disorder resulting from deficiency of NADPH oxidase, the enzyme responsible for formation of reactive oxygen species in phagosomes. The neutrophils affected by these disorders are unable to kill catalase producing organisms, resulting in recurrent bacterial and fungal infection that frequently involve the lung, skin, and lymph nodes. So the most important that we can learn from this graphic is the NADPH oxidase deficiencies that can produce chronic granulomatous disease. Okay. So now we're gonna read about interferon, type 1 interferon. We have here interferon alpha, interferon beta. Let's see what is interferon. So interferon is a group of signaling protein produced by the body to help fight viral infections and tumor. Remember, you have to relate in your mind interferon with virus, interferon, virus and tumor, virus and tumors, interferon fight virus and tumor. So a group of signaling protein produced by the body to help fight viral infections and tumor. They are part of the innate immune system, providing a rapid and prompt response to pathogens. Interferon can also be produced synthetically and used as a treatment for various conditions, including some cancers, hepatitis, and multiple sclerosis. this is a whole group of disease that have been used to treat with interferon. So interferon have been used to treat various conditions, including chronic myeloid leukemia, hepatitis B and C, lymphoma and melanoma, genital warts, early cell leukemia, Kaposi sarcoma, multiple sclerosis, and many other conditions. So interferons are produced by the body and they are created too by human or synthesized. So the mechanism of interferon, type 1 interferon, we have interferon alpha and interferon beta. A part of the innate host defense, interferons interfere with both RNA and DNA viruses. So interferon interfere with both RNA and DNA. Cells infected with various virus synthesize those glycoprotein. Cells infected with a virus synthesize those glycoprotein, which act on local cells, priming them for viral defense by downregulation protein synthesis to resist potential virus replication, and by upregulating MHC expression by facilitate recognition of infected cells. Also play a major role in inactivating anti-tumoral immunity. So we just learned before that interferon affect virus. Let's say interfere with both RNA and DNA viruses. The clinical use is they use for chronic HBV, hepatitis B virus. They be used for Kaposi sarcoma, early cell leukemia, as we read before, condyloma acuminatum, rectal cell carcinoma, malignant melanoma, and multiple sclerosis. So all those are they're being used. All those diseases have been treated with interferon. So adverse effect of interferon is flu-like symptoms, depression, neutropenia, myopathy or myopathia, pain in the muscles, and interferon-induced autoimmunity. So interferon-induced autoimmunity, myopathy, neutropenia, depression, and flu-like symptoms are side effects of interferon. This is very important. There's some questions about this, about the cell sulfase protein. Remember the T cells, TCR, bind antigen, and MHC complex. The T cell have CD3 associated with the TCR for signal transduction, and C28 bind to the B7 or APC, antigen presenting cells. The helper T cells associated with CD4, remember T helper, CD4, CD40L, CXCR4, CCR5. This I remember these two molecules are very associated in HAB. Here it say co-receptor for HAB. This is very high GL. Remember those are the co-receptor for HAB. CXCR4 and CCR5. They are co-receptor for HAB. Any questions with HAB, they most likely gonna show you those receptors. And as we know before, cytotoxic T cell CD8, helper T cell CD4, CD4 helper T cell, cytotoxic T cell CD8, regulatory T cells CD4 and CD25. Regulatory T cells, the cell surface proteins are CD4 and CD25. CD4 and CD25. CD4 like the T cell helper. So in B cells, remember we have the immunoglobulin. They have the immunoglobulin binding antigen. And then they're gonna show to B cell. Every time they talk about B cell, they're gonna give you the surface receptor CD19, CD20, and CD21. CD19, CD20, and CD21. receptors. The CD21 is a receptor for Epstein-Barr virus. So the CD21 is the receptor for Epstein-Barr virus. Remember, you must be 21 to drink on a bar. That helps you to remember that the Epstein-Barr virus, the CD receptor is CD21. So the surface receptor for natural killer cells is going to be CD16, and CD16 bind to FC portion of immunoglobulin G. CD16 bind to FC portion of immunoglobulin G. CD56 or 56 is suggestive marker for natural killer cells. So every time that somebody talk about CD56, they talking about natural killer cell. The macrophage, we have here the macrophages. The surface protein for macrophage is going to be CD14, and is the receptor for PAP, in example LPS, and then the CD40, and they have receptor like the HAB2, HIB, CCR5. They're gonna have they have a lot of receptors because they have receptor for AFC and CD3B receptor. Remember, opsonization, or receptor for phagocytosis. So the macrophage have AFC and C3B receptor and housing for phagocytosis. Remember, we have B7, we have receptor for MHSC2, we have receptor for CCR5 HIV virus, we have receptor for CD40, and we have receptor for CD14. So the macrophage is one of the most complicated to learn because I have a lot of receptors with the B cells too, because the B cells have receptor for immune globulin, they have receptor 19, 20, 21, receptor for Epstein-Barr virus, CD40 like the macrophage, MHC2 just like the macrophage, and they have receptor for V7, CD80 and CD86. This 80 here, this number 8, help you to remember that 8 look kind of that B, so it's gonna be a little more easy. V cells, CD8, CD86, the 8 kind of remember the B. And the hematopoietic stem cells, they have CD34. So here the natural killer, I don't know if that help you to remember, but think about natural killer, somebody who killed with a gun, and then they have in the magazine, they have 16 bullets in the magazine. They could have a magazine of 16 or a magazine of 56. So I don't know, that could help you to remember. The easy one is you must be 21 to drink on a bar. That reminds you that CD21 is the receptor for Epstein-Barr virus. Epstein-Barr virus. Receptor for Epstein-Barr virus. So we have here passive and active immunity. Let's see passive immunity. The main acquisition, the main way you get it is receiving preformed antibodies. So the passive way, the passive immunity is receiving preformed antibodies. It's going to be onset and a rapid onset. The duration is going to be short span. Whatever's come rapid is going to last short. Rapid onset with a short span of antibodies. Half-life like 3 weeks. So in that example, we have the immune globulin 8 from the breast milk. maternal immunoglobulin G crossing the placenta. Remember, this is the only one immunoglobulin that crosses the placenta. Immunoglobulin G. Antitoxin, humanized monoclonal antibody. The EVIG is like an intravenous immune globulin. For example, when you have some disease, very immune disease, and your organ is not working well, your defense is very low, you can get a immunoglobulin intravenously. So IV immunoglobulin and other immunoglobulin preparations can be administered to provide temporary but not specific passive immunity to a target pathogen. Okay, so when you get an immunoglobulin injection or IV, it's not specific for any pathogen. It's going to be like general. So the other side, we have the active immunity. So in the active immunity, the main acquisition is because you get exposed to exogenous antigen, specifically straight exposed to exogenous antigen. The response is going to be slow, and then the duration is going to be long-lasting protection. It's going to be memory. There's going to be memory. The examples are going to be natural infection. Let's say you got a flu, you got infection with any bacteria, you're going to have a memory. Natural infection, vaccines, and toxoids. So when you get the tetanus toxoid, that's some kind of injection, tetanus toxoid, or you get any kind of vaccine, or natural infection. We have a note that active here, active immunity. The combined passive and active immunizations can be given to hepatitis B or rabies exposed. So talking about vaccinations, in the next video, we're gonna learn about vaccination. We're gonna learn about live attenuated vaccine, killer and inactive vaccine, subunit recombinant polysaccharide and conjugated vaccine, toxoid, and messenger RNA vaccine. That's the one that they create for the COVID. Because this is something new, it's very likely that you're gonna see some questions about this. So messenger RNA vaccine. See, in this case, I have seen this in the news recently. Is about this kind of vaccine about the COVID, that they synthesize foreign protein, in this case the spike from the virus, but this spike in some patients multiply too much that they produce some damage in the tissues, or they can give you a heart attack or stroke. They trying to discuss this, is not 100% sure, but that's what they trying to investigate nowadays. This is still very under discussion, so it's not very likely you have questions about something that is still under discussion. But you just have to learn that this is the new kind of vaccine for COVID coronavirus. Here explain a little bit of complications. They produce myocarditis, very rare condition, very rare time. It's very rare, but they can give you myocarditis, pericarditis, particularly in young people. I remember when you get the COVID vaccine, they tell you that they can give you some myocarditis. Gonna learn about this. Thank you.